Health is not a state, but a continuous adjustment to the changing demands of life and environment. It would imply perfect functioning of the body and mind in a given social milieu. But for a nation to be healthy and strong, the surest and the best possible way is by preserving the health of its womenfolk. Welcome, ladies and gentlemen, to the program Dr. Tapaswini's Corner, and that's me, and I work as a head and neck cancer surgeon at the Fortis Hospital. Today's focus will be on gynecological cancers. To throw light on the various issues pertaining to this disease, we have our expert today, Dr. Rama Joshi. You are the Director of Gyne Oncology at the Fortis Memorial Research Institute in the NCR, trained at the Tata Memorial Hospital, Mumbai, as a UICC Fellow at BGH Buffalo, New York, University of Michigan, USA, and the University of Lyon, France. You've been the president of the Association of Gynecological Oncologists of India and have been instrumental in initiating DNB super specialty program in gyne oncology. Welcome, Dr. Rama, to the show.
I thank you for the kind introduction.
So today we are going to discuss about gynecological cancers with you. So what do we understand when we say gynecological cancers?
Whenever the cancer originates into the reproductive system,
right,
these are known as gynecological cancers. Like when it originates into the cervix, it is the cervical cancer. When it originates into the uterus, it is the uterine cancer. When it originates into the ovary, it is ovarian, fallopian tube cancer. And when it originates into the vagina, is vaginal cancer. And vulvar cancer. So these are all gynecological cancers.
Okay. So how common are these cancers in women? So if we compare breast, lung, oral cancers, where do these gynecological cancers fit in the Indian context?
Breast cancer is the most common cancer of the women of our country.
Correct. Right.
And the next common cancer is a cervical cancer.
Okay.
Cervical cancer, almost every year, new number of cases are around, say, 97,000. So it is the second most common cancer.
Okay.
After this, we have the third most common cancer as the ovarian cancer.
Mm-hmm.
And for the ovarian, the data suggests that around 45,000 of the women are diagnosed every year of the ovarian cancer. These are the two most common gynecological cancers, which makes the list actually of the top 5 cancers among the women of this country.
So the cervix and the ovary seem to be the more important of the gynecological cancers in India.
Right.
So when we view gynecological cancers, a great deal of it seems to be lifestyle related. And a fair bit is because of lack of our awareness about the reproductive sexual health. So how true is this perception?
I think this is a very correct perception, I would say. Because you will see the lifestyle changes, I mean to say, correlate the obesity. Obesity with that of the lifestyle diseases like diabetes and hypertension. These have been correlated well with the increased risk for the uterine cancer. Mm-hmm. And also certain situations like, I mean to say, certain styles like those who are smoking, that increases the risk towards that of the cervical cancer. And the reproductive health itself, means the sexual health itself, is the major risk factor for the cervical cancers. Like those women who start sexual activity in early age, those who are having multiple sexual partners, and sexually transmitted diseases. Basically, these are concerned high risk factors for the cervical cancer.
Okay. So when we look at the cervical cancer, it seems to be more prevalent where there is low screening and there's a high prevalence of this human papilloma virus. So we also realize that there's a lot of social and cultural issues in these cancers.
So those areas where there is regular screening program, there is low incidence of cervical cancer as well as the mortality is significantly low. But in the areas where there is no screening, usually these patients of the cervical cancer are being diagnosed in advanced stage of the disease. Say, for example, the United States. This was in the actually 20th century. At that time, it used to be the most common cancer of the United States. And it was the mortality was the highest. Now, over the period of years, when they could adopt to that of the regular screening, the mortality has reduced significantly to 80 to 90%.
So, what are the main causative factors behind cervical cancer?
The primary cause is the human papilloma virus infection. And this is the oncogenic human papilloma virus infection, not in general the other, you can say, the subsets of the human papilloma virus infections. Because the human HPV infections can be of 100 types. Right. And out of these, only 15 types of the HPV are oncogenic, and they will have high risk towards causing the cervical cancer.
So does that mean all patients who have contracted this HPV will actually transform at some period of time into cancers, into cervical cancer? Is there a latency period? And what is the percentage of people who are infected with HPV will transform?
In high prevalent countries, the incidence of the HPV prevalence varies from 10 to 20%. But we don't get to see that many cancers of the cervix. And these infections are usually seen in the younger age group, and they basically are asymptomatic and they spontaneously resolve on its. And what we are concerned about the oncogenic HPV, this is what is very, very important. When it persists for more than 2 years, then in that case, it is going to increase the risk for cervical cancer. And usually the latency, as you asked about, say, it will take another 5 years to, converting the histology into that of CIN3. CIN3 is the high-grade intraepithelial lesion that can be diagnosed within 5 years of having the persistent oncogenic HPV infection. And when these patients are not treated in CIN3 stage, then there is progression to that of the invasive cancers. Invasive cancers, it can even occur within 20 to 30 years. So there is a time lag between having diagnosed of CIN3 and then progressing into the cervical cancer. During this period, if suppose this patient is screened, then you can pick up, you can treat, and you can prevent cervical cancer.
So in other words, cervical cancers have a high correlation with HPV infection, almost to the tune of around 90 to 99%, if I'm correct. Viral infection is essential, but it is not sufficient to cause a development of cancer all the time. So it's a certain percentage which transforms. Is there a particular sort of a diet which is consumed predisposes these patients?
Diet which is rich, especially carotenoids, and also the diet which is rich in the folate that will protect the cervical cancer.
Okay.
So the colored fruits and vegetables, these are in the legumes, whole grains. So these are the kind of protective factors. That's how the diet has been correlated. So diet requires to be balanced. The other factors like oral contraceptive pills, right? If suppose the women are taking for less than 5 years, the correlation is seen that it increases the risk of cervical cancer by 10%. And it is actually the duration of the oral contraceptive pills which will increase the risk of the cervical cancer. When it is taken for more than 5 years, say 5 to 10 years, then the risk increased is say up to 30%. To 10 years, then the incidence really increases to 60%.
So there are some cancers which also run in families. Does this cancer also have similar correlation?
There have been correlation of cervical cancer also, but it is not a genetic correlation.
So how do these patients present to us in the clinics?
The presentation varies. Many of very early cervical cancer, there are no symptoms at all. These patients present to us with that of the cytology report of the either pre-malignant lesion or some kind of the suspicious cancer cells seen on the pap test. So they can be asymptomatic. And the second group, most of the time they present with the symptoms of, you can say, the bleeding after the contact, means postcoital bleeding. There can be increased discharge, which may be even the blood-stained discharge. They can be regular bleeding. In between periods, they can be bleeding, or they can be bleeding even after the menopause. But when the patient of the advanced stage presents, most of the time they are in pain. So these patients have a lot of backache. Sometimes the patients do also present with severe anemia. and even uremia.
And what I understand is awareness, one, and screening can get us these patients much early. Because as we realize, the precancerous and the early stage will always have a good prognosis. What are the battery of investigations that you run on these patients? Are there some tumor markers or radiology that we do, or biopsy through different techniques?
See, first of all, we have to prove whether it is invasive cancer or whether it is a pre-invasive cancer or micro-invasive cancer. When it is pre-invasive cancer and micro-invasive cancer, they do not have symptom, and when they are presenting to us with the report, we have to go for the confirmation of the diagnosis that we can do on colposcopy and directed biopsy. Otherwise, when the patient is having the gross lesion on the cervix, that is, we first of all actually define the confirmation of the diagnosis on the biopsy. Rather, we go for the metastatic workup that includes the radiological workup. We have either MRI of the pelvis or MRI whole abdomen. We also prefer PET CT. But
so when you talk of biopsy, doesn't the patient come up with some hiccups, and there is a lot of misconception? The moment you touch, it's going to flare up. So how do you handle these situations?
Yeah, I agree with you. Number of times I've come across, the situations. So, oh, Dr. Saab, it's going to increase, it's going to flare up. We just don't want biopsy. Just remove the uterus. Yeah. So people have the kind of the impression that the removal of the uterus is the treatment for the cervical cancer. And once we take biopsy, then of course it can flare up, or it can spread to, you can say it can go for the metastasis. We have to make them understand, without that we really cannot do the proper treatment for the patient unless we have the definitive diagnosis. And this was in fact the scenario, I would say, a few years ago, but now I think people understand better. They opt for the biopsy without any problem.
So now that we have made a diagnosis, it's time that we look into the treatment. So what sort of treatment protocols are we offering to our patients?
Yeah, again, it depends on in what stage they are presenting to us. Usual decision is the primary surgery or primary radiation-based treatment. In early stages, we prefer surgery because the quality of life of the patients after the surgery is much better. The morbidity of the additional, you can say, the treatment can be reduced. And that's how the surgery involves the radical hysterectomy. But in the stage of stage 1B3 disease onwards, we do not go for the upfront surgery as a treatment. Okay. And the treatment of the patient is the radiation-based treatment in combination with that of chemotherapy. We call it as concurrent chemoradiation.
All right. So what all are the issues that you have to handle post-treatment? Are there some complications? Are there some long-term sequelae that you get to see, and you really need to help them to cope up with it?
Yes, I think there are morbidities, and the morbidity depends on the type of the treatment which we have chosen for the patient. One is a surgery, the other one is a radiation-based treatment. In surgery, there are advances in the surgical management of these patients of the early stage cervical cancer. Bladder dysfunction after the surgery used to be a major problem for us. And the incidence then used to be, say, around 30 to 40%. So after actually changing the practice in the surgery, that is the nerve sparing radical hysterectomy, which we do, we are preserving the autonomous nerves which are going to the bladder. Okay. And the bladder dysfunction has significantly reduced to even less than 12%. So it is a bowel dysfunction and the sexual dysfunction to some extent. These all can be reduced with the preservation of the, you can say, the hypothermic nerves. So radiation-based morbidity can be there. Because of the changes in the technology these days, this also has come down significantly. And most of the time it is seen as that of the leg edema. And leg edema incidence has also gone down. It can be cystitis or radiation-induced proctitis, which we see as that of the delayed complications. What is important is that the change in the treatment selection is that we try to avoid combination of these two treatments. Means we try to select the patient best for the surgery so that in such a way that we don't have to combine the radiation therapy so that we can reduce the morbidity. Otherwise, the combined treatment morbidity is comparatively much higher.
Okay. So you are trained in robotic and a lot of minimal invasive surgeries. So has robotic surgery, has it made some change in our surgical approach?
This is a surgical advancement. And in this, the surgery is much more precise. There is minimal blood loss. And actually, patient recovery is very fast. Their hospital stay can be reduced. And usually the patient goes the very next day. In cervical cancer, we are restricting robot-assisted surgery to very early microscopic disease. We can surgically stage using this technology of the minimal access robotic surgery in cervical cancer.
That's wonderful, wonderful. So if you look at cervical cancer, it's a highly preventable disease and a lot of vaccines have come into the market. So what is the ideal age group and how effective is it?
Cervical cancer is preventable, as you said, and primary prevention universally is with the use of the human papillomavirus vaccine. This is the vaccine which basically caters to human papillomavirus 16 and 18. When it is given to the adolescent girls, effect is almost complete effect against HPV 16 and 18. Maximum effect is possible when it is given before any sexual activity the girl begins.
So this comes as a preventive vaccine. Is there any research which is going on which would come out with a therapeutic vaccine which can treat this cancer?
Yeah, I think there are phase 1, phase 2 trials going on for the therapeutic vaccine. There is no phase 3 trial, and these are not FDA approved. These are for the research purposes. Screening is required rather advised after the age of 21 years.
Okay.
But we have to, this is known as the age, you can say, the age adjusted screening program. Means if the girls are young, because the type of the screening test which we choose, that is based on the age.
Okay.
And when the young women or the young girls are there, that is 21 years to 30 years, we usually screen them by the PET test or the cytology. And when the age group is between 30 to 65 years, we incorporate HPV DNA testing. That is high risk HPV DNA testing along with that of the cytology. The interval of the screening or the interval between the two tests, if you are combining these two tests after the age of the 30 years, then you can go for the 5-yearly screening. Usually, actually, we can stop screening around, say, by 65 years of the age group. Suppose a patient was diagnosed of the CIN2 earlier, then we will have to continue, the screening program even beyond the 65 years of the age for another 20 years. Even after the primary prevention with that of the vaccine, the women must go for the regular screening. There is 18% risk for the women who had been vaccinated for getting cervical cancer.
Perfect, perfect. So now let's move on to the ovarian cancer. And this seems to be a disease which has a wide age range. You can see an infant with ovarian cancer, you can see an elderly. So what sort of a spectrum of diseases and why is there so much of an age variance?
These cancers are of two types. One is the germ cell tumors. Germ cell tumors we will see in the adolescent girls and the young girls or the young women up to the age of 30 years, most of the time. These are the type of cancers who will be diagnosed comparatively in early stage, and they have a very good prognosis. They have a good chemosensitivity. So the survival results in the germ cell tumors, even if the patient is in advanced stage of the disease, and they have good survival results. On the other spectrum, we have epithelial ovarian cancers. The risk increases as the age increases. And most of the time, they are being diagnosed near the menopause or even after the post-menopause, around 50 years of the age and above. These are the patients who present in the advanced stage right in the beginning. And this presents the challenge to the management. Around 85% of these patients will have the high-grade serous tumors of the ovary. And in this situation, we have to offer, the surgery and chemotherapy as a combined treatment approach. Sometimes we may have to consider chemotherapy even prior to the surgery. The surgery will include the very extensive surgeries, that is a cytoreduction with the aim of removing all abnormal areas from within the peritoneal cavity, including even the pelvic peritoneectomy, the undersurface diaphragm peritoneectomy, total peritoneectomies, bowel resections, and anastomosis. The aim is, yes, achieving no gross residual disease at that of the optimal status.
Right.
And it has been recommended that whenever the patient is having suspicion or diagnosed of ovarian cancer, they are best managed when they are managed by the gynecologists.
Correct.
Because the treatment actually is a very complex treatment in these patients.
So patients should know whom to approach when they have, and even our doctors need to refer to the proper specialist for their treatment. But as you said, most of these ovarian cancers are presenting late in the disease. Doesn't the body have any sort of a symptom or warning signs which is given to the patient, or is it very innocuous?
This is a global scenario that the 85% of the patients are presenting into the advanced stage of the disease. This is mainly because the kind of the behavior in which the disease spreads to the peritoneal surfaces. There are no definite symptoms initially. The patients will have the vague symptoms. And these vague symptoms like that of the dyspepsia, patient feeling full after eating even a small. There is some kind of discomfort in the abdomen. But these are the vague symptoms. Patient sometimes, correlates with that of the GI symptoms and presents to the gastroenterologist and then goes for some imaging. They find out, oh yes, there is the ovarian mass or there is the evidence of ovarian malignancy. Other than this, when there is distension of the abdomen, sometimes they do have increased frequency of urination and also the constipation.
This would mean a fairly advanced stage that you're talking about? When they start having bowel obstruction.
When they start feeling discomfort,
Exactly.
already the disease spread is such. Otherwise, in early stages, the patients who are going through the annual health check and clinical examination reveals that there is ovarian mass. 15% of such cases, they present in the early stage. But again, they require a very definitive treatment because we don't know what kind of these masses are. And we have to prove it on table using the frozen section facility.
So who are these women who would be at risk? Well, these symptoms we have already talked about, but are there a particular set of women who should be forewarned, should be cautioned that yes, you can in future have such a disease?
The age of the patient is more, the incidence of the ovarian cancer is more. Other than this, those who are having the familial cancer history, they can have increased risk of the ovarian cancer. Those history of the breast cancer, ovarian cancer in the family, or colon cancers, even in the male, the prostate cancer and the male breast cancer, pancreatic cancer. These are all the group of patients where we should really think that this is a familial cancer and they are likely to have increased risk of developing the ovarian cancer. So these are the patients where we can go for the BRCA mutation testing and we can see whether they are at increased risk for developing the cancer or not. Other than this, those who are infertile, they do not bear the pregnancy. Pregnancy has got a protective effect on ovarian cancer. These are the ones who will have the increased risk for developing the ovarian cancer.
If you look at the various tumor factors, I think there are certain substances which are produced by the tumor, which we can actually estimate and figure out, yes, the disease is probably lying in the ovary or in a particular area. So are there any tumor markers which can pinpoint out to the site of the pathology?
Yeah, we have the tumor markers like CA125, we have CA19.9 and CEA. Sometimes it is the primary is GI and the spread is onto the ovary or maybe into the peritoneum. And these markers will definitely help us guide that whether we go for the colonoscopy in order to exclude the primary colonic cancer or the upper GI endoscopy where we have to exclude the primary stomach cancer.
And do they also speak about the volume of the disease which the patient might be harboring? The levels of these markers, do they have?
Yeah, but actually not exactly always. The markers are not that sensitive in ovarian cancer.
All right.
Even in 30% of the cases where the patient is having very advanced disease, the markers can be normal. I mean to say you find that the CA125 can be normal in such cases. You have to clinically evaluate the patient and then we have to take the decision.
So we also hear some role of prophylactic surgeries in ovary. We hear the famous story of Angelina Jolie undergoing prophylactic mastectomy and bilateral salpingo-oophorectomy. So where is this role of prophylactic surgery in these diseases?
Yeah, there is a role of prophylactic surgeries. Those who had suffered breast cancer earlier, and all those who had the familial cancer history, the BRCA testing is done, BRCA1 and BRCA2. If suppose they have the BRCA mutation, the likely chances of getting the ovarian cancer is as high as 20 to 40%. And also the breast cancer is as high as that of say 60 to 80%. So I think there is a role of prophylactic surgery in these patients, because we do not want to take up 40% risk for the ovarian cancer. These cancers originate within the fallopian tubes. So prophylactic, we have to remove the fallopian tubes as well as the ovary. Okay. This will reduce the risk by 95%. Still, there are 5% chances of developing the primary peritoneal carcinoma.
So how compliant are our Indian women to these surgeries?
Now the women are coming. See, the incidence is more now. We are getting more patients of the familial cancer. They are coming forward. They are more aware. So basically they come forward for their own genetic testing. And sometimes they come to us with a report that BRCA mutation is there. And they go for it. But the thing is that they can complete their family. And after that, they can be offered these surgeries. Before that, we can offer them some kind of contraceptives as a protective, because if suppose you give the oral contraceptive in the younger age group, it protects ovarian cancer. When it is given for 5 years, reduces the risk by 50%.
Okay. So the magic word actually is education. Education and spreading awareness among the women. Ma'am, let's share your final message to the listeners. What would you like to convey to them with respect to these diseases?
I would like to convey that they should have healthy lifestyle, healthy diet, do not smoke, healthy sexual life, and healthy spiritual life. These are very important factors which can reduce and prevent the cancer by about 30%. And for the prevention of the cervical cancer, the adolescent girls and the young women should have primary prevention by giving the vaccine, that is HPV vaccine. And those who feel healthy, those women should come forward for their regular screening with either Pap test alone or Pap test in combination with the HPV DNA testing. We can reduce the incidence of the cancer and prevent the mortality by 30%. And for the cervical cancer, we can prevent up to 82%.
That's a great message. And thank you so much for sparing your time, valuable time, and for giving us some time for the program and all the valuable information that you shared with us today. But before I end, I would love to quote Swami Vivekananda. He said, "The best thermometer to the progress of a nation is its treatment of its women. There is no chance for the welfare of the world unless the condition of the woman is improved, because it is not possible for a bird to fly only on one wing." Thank you once again. Thank you so much. Thank you to all the listeners.
I congratulate for conducting these programs. These definitely, I'm sure, will help the women of this country to really have some kind of awareness. This will increase awareness, this will increase prevention and give the quality of life to our women.
Well, that's the need of the hour. That's the need of the hour. So I thank you once again. Thank you, listeners. See you next week with another expert on another cancer. Till then, goodbye.
Thank you.